All right. Thanks, everyone. I'm really excited to introduce this next panel. We will have one in-person and one virtual presenter today. PPMD really recognizes the importance of understanding the Duchenne brain. We were really privileged to gather with an academic meeting last November in New York City to really bring all of the people together, the neurologists, psychologists, scientists, behavior experts, and really start to unpack the effect that dystrophin has on the brain in Duchenne. So, as a result of that, we've got a couple of really spectacular presentations for you today. And to start off, we're going to hear from Dr. Erik Henricson of UC Davis. And with no further ado, I'll go ahead and hand things over to him.
Thank you very much. Good morning, everybody. So I'm going to try to stay on time today. So yeah, I'm Erik Henricson. I'm from University of California, Davis, and I've been lucky enough to be a part of this group of some really cool international scholars starting to think about DMD brains. And not just DMD brains, but kind of like what's the role of dystrophin in the brain, and what do we understand about how dystrophin in its various forms affects the individual's behavior, because we know that there's kind of a DMD behavioral phenotype that we have to think about. And so just to orient everybody, we primarily think about DMD as a muscle disease, but it also it's multi-system, right? So we have pulmonary challenges, we have cardiac challenges, and things with bone density, but there's both full-length and then shorter isoforms of dystrophin in the brain as well, and they serve to help to anchor some different structures in neurons and the brain in general. So what do we think? What do we know about developmental challenges that people with DMD and dystrophinopathies often face, both in early childhood and throughout their lives? So we know that folks, there's a variable degree of cognitive delay, and it's it's been reported as for full-scale IQ that there's a 1 to 1.5 standard deviation decrease below the mean on average for people with DMD, but that the range of IQ intelligence is within what we would see in the typical population, that we often see some form of language delay, and it's often one of the things that first concerns parents when they have a child with DMD, and it's one of the things that they first notice in early childhood. And then we have some social behavioral delays. Some people would call them deficits, but I think we can see that in many cases that these are simply that people are maybe a little bit younger in the social context than their age, and that there is some catching up as well. And then we also have comorbidity with autism and some other like ADHD kinds of behaviors that are in many cases called autism as a co-diagnosis, but that may be a little bit different, but definitely at a higher prevalence than in the typical population. I'm hitting the wrong button. So the shift in full-scale IQ, as we understand it, is primarily due to what we see as changes in receptive language, how we process verbal information, with verbal working memory rather than like a performance IQ. So this is really how it really has to do with how we understand, how we take in and understand and process verbal messages, and then respond to those. And we see that that actually, if we look at some of Ann Connolly's work in young children using the Bailey scales, that there is some verbal delay, but it seems to catch up as children age until they're up in the typical range. And we see that in addition to those kind of verbal processing challenges, that we see some delays in differences in recognition of facial affect and nonverbal reasoning, some social perception skills, and some reduction in initiation of social interaction. That's what I'm going to talk about a little bit more here. So if we think about what's recommended for developmental assessments for people with DMD, and in the care considerations papers, they really do, in addition to looking at the physical milestones. There's a recommendation to look at sort of developmental milestones, including the social communication part. And that's an indication for some early screening, early testing, early intervention on the behavioral side as well. It's not something that everybody needs, but it's something that everybody needs to be attuned to, even in the young children, preschoolers. And that setting families up to help maximize kids' performance in the school and the social arena is just as important as thinking about setting families up to deal with physical challenges. So neuropsych evaluations are one of the common ways to kind of get a baseline and follow people over time. And that's something that ought to be done on a regular basis in the clinical context from a multidisciplinary clinic standpoint. It helps to identify specific areas of strength and weakness for individuals, because we're all different. Where we can help to kind of pinpoint areas where people might have some skills they need to work on in order to maximize their ability to be successful in school, for instance, whether it's listening or whether it's following instructions or whether it's making eye contact and being able to not freak out when we look at somebody and be able to then kind of listen and process what they're saying to us. And these kinds of evaluations should be done throughout the lifespan. And we all change. We're all in different social contexts as we age. We go from preschool is totally different than middle school, is totally different than high school. And we have different kinds of things that we need to work on in those different situations. And that goes for all of us and for people with DMD as well. So if we think about early childhood, right, and there's been a lot of talk about autism in DMD, and we look at these autism screening tools. Amy Wagner at University of Wisconsin did a really great project for her PhD dissertation, actually, that looked at kind of some of the standard parent report screeners for autism-like behaviors and autism-associated sort of behavioral phenotypes, and looking at identifying, for a suspected autism diagnosis, people fall into this high-risk category. And what she did was she said, okay, if we look at this at-risk category and we think about kind of moderate behaviors that have some impact on day-to-day life, whether it's in the family or in the school, things like that, how does that look in terms of people, if we think about people with DMD who don't have frank autistic-like behaviors that are severe clinically, we start to see that they're using the Ages and Stages questionnaire. We see changes relative to typical controls in this toddler age group in communication and gross motor and fine motor. But also we look at these personal, social, and socio-emotional domains where there's a very significant difference in the frequency of these mild to moderate behaviors that could still have an impact on family and learning and school performance. Looking at the same thing with the Strengths and Difficulties questionnaire, we see a similar pattern with a higher degree of sort of emotional regulation symptoms, conduct problems, and peer interaction problems that kind of that kind of combine to create a higher prevalence of social difficulty in people with DMD. And if we look then at the social responsiveness scale, which is another one of these screeners, we can see that social motivation, this is one of those things that's been understood in the DMD population for a long time, that people with DMD, it was sort of quoted, lack a drive to make sort of the first step in social interactions. And we see that very clearly with the SRS tools, even in early childhood and toddlers. And we also see some differences in social communication and interaction and in sort of repetitive behaviors that highlights that there are some things here that we need to be tuned into in toddlers and preschoolers as early as that, and that there are things that we might want to start to think about to intervene in those areas when strength is of a concern, but is not the primary concern in the early kids, in order to maximize their success from a peer relationship standpoint as well. So how does this all lead into brain? What do we know about brains, and how do our brains process social information? And what does dystrophin do in that context, we think? Right? This is a very new area, so we don't have a lot of solid data other than in animal models on this, right? But let's talk about this is the old brain, the slug brain, people call it. This is conserved over, millennia of evolution and across multiple species, right? There's this limbic system, and this is the part of our brain that is the fight or flight part of our brain, basically, and it takes in auditory and visual information, helps us to decide whether there's something threatening or warm and fuzzy, and helps us to figure out how to respond to that. Okay, so they call this kind of the snake and stick system, right? So you see these two things, one's a snake, one's a stick. We don't have a lot of experience here, but somewhere along the lines, maybe we start to learn that snakes can be maybe not so great, might be a little threatening to us, and maybe there's a stick. Then we know sticks aren't particularly threatening, but this one might look like a snake. Our brain has to figure that out, and has to figure out whether that's something we're going to go pick up and play with and build a hut with, or are we going to run away, or are we going to use that stick that we found to make sure that we can beat off snakes in the future. This helps us we're taking in visual information from our environment. And this goes through multiple parts of our brain, different pathways that involve our sensory cortex, our visual and auditory cortexes, and also the parts of our brain that control memory, right? And this is all processed through a little part of our brain called the amygdala. And this is kind of like we have between our prefrontal cortex, right, the thoughtful part of our brain, and the amygdala, which is the one that goes and helps us run away and gets our blood pressure up and our heart rate up and makes us gets our muscles ready to move and run. This is the process that we go through. And as we see in people with sort of anxiety disorders, that the balance between the signals from those different parts of the brain can be a little bit dysregulated. So we have we think of these as different processing nodes, right, in the brain. So we have this detection node. This is the earliest maturing one that we have, and this helps us to learn to pay attention to, mom's face after we're born, and to distinguish biological from non-biological motion, so that if there's a bear over here, we might be a little bit worried and go and run to mom. But if it's just a tree moving back and forth, we're like, oh, it's just a tree. It's just wind. We're going to be fine. But it also we start to categorize, family members versus strangers, and these are the kinds of things that helped us stay alive when we were but in early development, way back when. So then we have this affective mode, which helps us sort of organize how we respond emotionally to things, right? And this helps us with understanding people's facial affect, like what, a friendly face, somebody smiling, hey, how you doing, coming up, versus somebody who comes up and, I'm really mad at you. And your physiologic response, you can actually physically feel that when people come up to you. That happy kind of relaxed attitude face, and you're like, oh, we're ready to learn something. I like these people. I'm gonna hang out. I'm gonna have some sort of positive, rewarding social interaction with this person, versus this person looks really threatening. I don't think they have my best interests at heart, and I might need to run away. And you can actually physically feel that, and I think all of us know what that kind of feels like. So this is the next part of the brain to mature. And then you have this regulatory node, which really, realistically, we don't fully mature until adulthood. And some of us maybe a little bit past adulthood. And this is the part that we call sort of the thoughtful part of your brain, the prefrontal cortex. This is where you are trying to, we social reference a lot as little kids, right? Something happens, you see somebody over there, you look to mom to see if mom has some sort of evidence of like arousal, like she's happy to see somebody and smiles, or she's gonna look concerned and grab you and get ready to run away. We don't really know how to do that right off the bat. And eventually we mature and we figure out how to do that ourselves. And then people around us start to social reference us instead of the other way around. So that's what this part of the brain does. And the effect here is we see a visual stimulus, it comes in, we have to decide run away or be friendly, right? And so in the typical brain, this is controlled by this regulatory node, and this is like the brake pedal on your amygdala, right? So amygdala starts to go, we gotta do something, and the brake pedal goes, no, dude, chill, we're okay, right? So what's my next slide? We see evidence of imbalances in these systems in multiple different developmental disorders. We have people with autism spectrum disorders where these pathways work a little bit differently. In Fragile X system, in people with trait anxiety and mood disorders, we have a lot of things like resting tachycardias, kind of that you're in that low grade fight or flight, ready to respond to something, always on alert, kind of all the time. And we know that people with DMD, for instance, have some low grade to moderate anxiety challenges that go along with the disease. And part of it is a lack of mobility, but part of it is actually innately related to how the brain processes information. And one of the things that ties into this part of these two parts of the brain, right, the amygdala, the hippocampus, and the prefrontal cortex, this regulates how we respond to social stimuli. So this is our old brain. This is a little cartoon here of our basolateral amygdala. So little tiny, it's like the size of a grape on two different sides of the brain. And the one portion that accepts signals in and helps to decode the brake signal from the prefrontal cortex is the basolateral amygdala. That has a lot of dystrophin in it. When we lose that dystrophin, what it seems and what our current working model is that you have fewer GABA receptors. And GABA is one of these neurotransmitters that is kind of a regulatory, calming neurotransmitter. And so if you're lacking the receptors, and the dystrophin actually helps to anchor those receptors in the cleft between at the synapse, then no matter how much GABA is going out into the, from the prefrontal part of our brain, it's not hitting the target as efficiently as it could, which means that the amygdala can kind of do its own thing. So here's what happens this is how this balances out when you see a friendly face. This is all of us, right? So see a friendly face, your amygdala kind of goes, something's going on here. You get information from the visual cortex. Some of it goes a little bit through the cerebellum. I won't get into that. But then you have this, your experience tells you, look, that's David. I like David. David's a really cool guy. I know he's not going to hit me with a stick, right? So I don't have to worry. I have that prefrontal control here. And so I have lower heart rate. I'm able to attend to things more clearly. I can often remember information that's told to me more efficiently. And so this is the way that it works in typical social interactions. Now, if we see threats in the social environment, something a little different happens. So this is where this threat signal comes in. The amygdala goes, wow, okay, you actually have a heightened signal through the amygdala. And this, you've got that PFC, GABA, braking, chill out signal is still there, right? But it's being overwhelmed by the signals through the amygdala. And we're then inclined to, we have a higher heart rate. Our heart rate isn't as variable. We might be anxious or agitated a little bit. We're probably going to be maybe just start to feel a little bit aggressive in case we need to fight back. And this sort of this decreases our effectiveness at social interaction, right? Because I don't necessarily, if I feel like that, want to interact with you. I'd like you to go away, right? So, and this changes the way that we can attend to messages if we're supposed to learn, for instance. And it reduces our kind of working memory. So if you've ever been in that like heightened sense of alert and somebody's trying to tell you something at the same time, like think about, you know, kind of any doctor's visit ever, that you're less likely to remember what's going on in that context. So we know, and this is just some nice pictures from a really great paper from a Japanese group back about 10 years ago looking at the MDX mouse and co-localizing dystrophin and GABA receptors. This is the evidence that we have right now. We need to look at this in people, but nobody really wants us to go digging around in people's brains. So, you know, there are things that we're gonna have to do kind of to work around this, but the mouse model is a good place to start. The mice, MDX mice are known to have this kind of atypical freezing effect, right? So they have that kind of same, like their fight or flight is going a little more, and when you really startle a mouse and stress him out, we talk about that deer in the headlights thing, this is what mice do too. I'm just gonna stay here, maybe nobody will see me. I won't get eaten. Well, MDX mice do this at with a very low excitation threshold, right? You can basically, you just are around them and they do this, versus wild type mice with typical non-dystrophic brains. So what's going on there? Well, here's what we think is happening in people with DMD. So we think that in the context of seeing maybe not happy faces. Happy faces have a pretty high, like, they really happy faces stimulate that warm, fuzzy part of our brain, right? But if you think about neutral faces, who's got, even typical teenagers, right? I've got a 15-year-old at home, and I can just walk by him with, like, thinking about, like, what I'm gonna cook for dinner, or the fact that I need to, like, weed the garden in the back, or something like that, and he'll look at me and go, what? What did I do? And I'm like, nothing? Why are you mad at me? I'm not. But this is really interesting, because during adolescence, one of the typical remodeling things that happens to our brain is that as our brain is in this kind of hormonal, you know, mix that happens, is that we prune off a lot of these excess connections that we need, that our childhood brain needs. And one of the major areas that gets pruned is this link between the prefrontal cortex and our hippocampus and amygdala. And a lot of those pathways get reduced. So in adolescence, we have a harder time interpreting facial affect, especially neutral faces, which we are thus more likely to assume are threatening. So this helped me out a lot when I got teenagers to kind of, okay, well, your brain has a bunch of stuff just disconnected right now, so I'm just gonna roll with that and we'll be okay with it. But I just say to my guys, understand the parts of your brain that are not connected now. And they roll their eyes like, I wish you didn't know this stuff, Dad. So in a dystrophic, the brain of somebody with a dystrophinopathy, what we think is happening is that it's basically like you're starting off with that pubescent level of some of these the pathways are disrupted. So when you see these neutral faces, your amygdala has a very typical, we think, a very typical response. But the thing is that now the brakes are gone, right? So you have a reduced signal coming from the prefrontal cortex into those pathways. So even though typical everyday level of input is happening and it's not something that's big and threatening and it's gonna make you anxious, you're feeling it that way anyway, because those PFC signals, instead of, like, if you start out, let's think about it this way, right? So here's your typical level of amygdala response, just looking around the room, nothing exciting is going on, and this is what your PFC is doing, right? And so for you to feel anxious, your amygdala signals have to be up here. Well, we have the opposite happening here, where your amygdala is down here, da-da-da-da-da, just kind of cooking along, but your PFC signals are down here. And this difference is what causes that anxious feeling, right? So this is what we think is going on. And when we have those anxious feelings, our heart rate is up, we're not remembering things quite as well, our working memory is not as efficient. Think about working with just people, when you're anxious or your kids are anxious, think about, giving multi-step instructions. Go to the refrigerator and get me a glass of milk, whatever. And they get there and they like at the fridge and then they've forgotten why they're there. It's this kind of thing. So this I think will help we have to put some numbers on this. We have to really prove this hypothesis. We're working on this part. We're not there yet. But we do think that from a standpoint of kind of behavioral interventions, that this gives us a place to start, and it gives us a working model of what we think is going on, and it probably will give us some ideas about kind of how to step in and help people be as successful as they can bearing these models in mind. So I believe that's my takeaway for this one. I'm going to hand it off to Natalie. But these behavioral characteristics are present in infancy. Some of these characteristics that we see are shared with other developmental disorders where social interaction and impairments of that social interaction exist. These are old brain pathways that are evolutionarily conserved that we see in everything from like slugs to cats to, emus, anything, higher order mammals. These brain pathways are dystrophin rich, so it stands to reason that when we start to jimmy with dystrophin and have reduced levels, things are going to regulate a little bit differently. And so the take home here is, for now, right, that there may be interventions that help this as well as muscle in the future. Right now, we should make sure that your school and your care team and your family understand that there's some brain stuff going on here that ought to be addressed as early as possible. And that there's no bad time to address this, even in adults, because the needs are going to differ over the lifespan. So I think we'll take questions after Natalie's talk, and I wanted to thank everybody here who's been fantastic at collecting some of the data that I showed, and thanks very much.
Thank you, Erik. All right, that was fantastic. I'm grateful for my amygdala to know that you're not going to hit me with a stick. Next up, we have Dr. Natalie Trouba. She's a psychologist from Nationwide Children's Hospital. Unfortunately, she was not able to join us today in person, so you are going to see a pre-recorded video. And then afterwards, if there's time, we'll actually kind of pipe her in, and we can do a Q&A with both Dr. Truba and Dr. Henricson. So if you have any questions, jot them down, and we'll get to them at the end. And I think I will turn it over to my AV guys in the back to go ahead and pop Natalie up on screen.
Hi, I'm Natalie Trouba, and I'm a pediatric psychologist at Nationwide Children's Hospital, and I'm really excited to be here with you all today to talk about the clinical management of learning behavior with dystrophies. I have one financial disclosure is that I'm a paid consultant for PTC Therapeutics, and otherwise I'm just going to jump right in it. And so as all of you know, as parents, families, and providers of kiddos with dystrophies, is that we see a lot of really challenging behaviors brought into clinic. Not always to the same intensity or degree, right? There's a big spectrum in these boys as they are unique little individuals, but we see some commonalities. And what we see are those things like learning problems, difficulties with attention, or ability to sort of ignore, suppress extraneous information in the environment. We see some unique or interesting sort of information processing patterns and memory recall abilities. We see sleep difficulties, we see reduced tolerance of distressing things in the environment, particularly like loud noises or other harsh sort of sensory stimulus. They had a harder time transitioning between activities, between events, between slow to fast, fast to slow sort of situations. We see those kind of rage-like meltdowns, higher rate of selective mutism than we would expect. And then we see some of those more challenging behaviors like that perseverative, reassurance-seeking, OCD-like behaviors, particularly when a little bit more anxious. And as Dr. Henricson was talking about in his slides, there's really important to understand the role of the brain and how the brain and body work together to kind of create regulation or kind of create a regulatory homeostasis for anybody, let alone these boys. And so what we know is there's a lot going on in the brain, particularly from a dystrophy standpoint or lack of dystrophin being produced in the brain, that is really impactful from a brain regulation standpoint, from a neurophysiological regulation. And so what seems to happen is the brain is much more excitable and from a glutamate learning standpoint, just really activated. And there tends to be sort of a bombardment of sensory stimulus in a way that their brains do not habituate, or there's not sort of a reduction in sort of excitatory processes as we would expect. And what happens is there seems to be this sort of overactivation of the sympathetic system in the way that the brain is always kind of responding to stimulus in the environment in a way that is disproportionate for what it should be, right? It's over responding to them. When we look and happens what's in the muscle, there's a synergistic effect here. And I'm going to talk about this on my next slides a little bit and kind of show this in a different way. But what we see is this impact on the breathing muscles, particularly those abdominal and those chest breathing muscles, that results in this sort of choppy chest style of breathing that when, without being anxious can be very problematic. It's problematic for anybody when you're anxious, right? Because if you stay in that breathing pattern long enough, you're going to induce a panic attack. And that happens outside of conscious awareness. But for these boys, what happens is it seems to impact this activation of the sympathetic system. And so the sympathetic, parasympathetic systems are not working together as we would expect them to. And I'm going to show you what that kind of looks like on the next slide. And over time, what happens is they seem to have this chronic physiological arousal pattern where their distress tolerance threshold or their window. So we kind of think about how we can tolerate life as a window, right? And sometimes our windows are very big and sometimes they're very small, depending on how we are, right? Are we getting good sleep? Are we rested? Are we eating well? Do we feel okay? Those types of things that help us better tolerate kind of things, demands put on us. That gets smaller, right? As we're chronically physiologically aroused. And over time, what happens is when we have a small window is we start to see sort of much larger physiological responses to perceived stimulus, whether that's neutral, positive, or negative. And over time, we start to see sort of a maladaptive way of coping with that in response, because what happens is from a neuronal level at a glutamate-based learning and then an operant level, right, we are learning how to, produce that physiological pattern in our brain in that environment, and then to sustain it in a way we wouldn't otherwise through learning processes. And this is really important because over time what happens is that pattern starts to impact how we perceive and interact with our environments. And so if you're somebody who doesn't like your job or has been in a job you haven't liked and you're in a good mood, kind of maybe when you leave home, and as you get closer to work and you get into work, you might notice that shifts and you start to notice you feel different. Nothing has happened other than your body has learned that this is an environment where this is the way that I feel. And it is producing and changing at a neurophysiological level, at operant learning, right? And producing these things that is causing a change in your internal state without an actual shift from a stimulus response, right? Your body has learned to feel this way in this environment, so it's feeling that way in that environment. And over time, this creates this behavioral phenotype for these boys. And that's important because they all are different, right? They're unique little individuals, like I was saying, but they tend to have similarities in how this behavioral phenotype looks from a physiological arousal standpoint. And then we put them on steroids. And steroids are really important, and they're needed, and we need to keep our boys on their steroids. And they definitely kind of throw fire into this process a little bit. And so it's important for families to understand that this is challenging, and it's challenging for everybody. And it's really important that we get a sense of how do we manage this to the best of our abilities. And manage does not equal zero. Manage is how do we reduce the intensity of these behaviors, the frequency, the latency between recovery and helping kids better cope with and prevent sort of those bigger meltdowns. And so when I utilize biofeedback with these boys, and this is a truncated, very simplistic way of thinking about this, so I apologize about that. But when we think about kind of how this looks, for those of us who don't have dystrophinopathies and are not significantly anxious, your physiological pattern throughout the course of a day will look something like this. This is happening outside of your conscious awareness. Your body is escalating, sort of it's activating, it's getting ready to do stuff, and then it's kind of calming, and it's shutting down, and it's hanging out for a bit. And this is how our body self-regulates, neurophysiologically body muscle, right? And so our brain is calming, our breathing changes, that tells our brain, cool, stay calm, and we can kind of self-regulate, and that happens. If you're more anxious, you might notice that you have bigger swings in this pattern, or times that you're more aware that you're feeling more over-aroused than otherwise. But for most of us who are not significantly anxious and don't have dystrophinopathy, you're going to be somewhere in here throughout the most of the day, and you're not going to notice this happens. I walk to work, so if I'm walking to work and I almost get by a car, I'm going to have a big swing in physiology like this, right? My body's going to be like, whoa, that was scary. And I'm going to notice that because I'm getting the top of that window that we were talking about. I have a pretty good window, but I'm getting the top of it, so I might notice my thoughts change from kind of in a good mood, I'm walking to work, to a very sort of like negative, like, hey, watch it. Or I might notice my heart rate increases. I might notice I get hot. I might notice that I feel a little bit more like jittery, or I feel a little bit more restless in my hands or something. But I'm going to calm quick because, again, I'm not super anxious. But if I was, you might notice more of this line kind of extends out this way, right? Or extends out this way a little bit slower. And so for these boys, what we see is a little bit more of a pattern that looks like this. And this is an indication of that brain piece, right? Of there's something going on with the brain that's escalating them and making them very sensitive to hyperarousal that's kind of kicking them up all day. And then you can see that there's these periods of where they attempt to shut down, but it's interrupted, it almost looks like. And I think that's where we see this muscle-brain synergistic effect of that weak muscles and that diaphragm and around those, the inspiration, expiration muscles that cause that choppy chest-style breathing that kind of gets in that way of that sympathetic system staying shut down or working as well as, parasympathetic system is working as well as we would want it to work. And so in many ways, they just present as really physiologically overwhelmed. And this is similar to what we see in our MDX 23, 52, and 71 null mice, in that they seem also very physiologically overwhelmed. And there are a lot of factors that contribute to this presentation. I'm not trying to oversimplify our mice data by any means and compare them to humans, because they're not. But we see these similar patterns in mice that are null of dystrophin. And we see a robust, much higher unconditioned freeze response than we would see in mice naturally wild dystrophin producing mice and in boys who are producing dystrophin. And so we see a much bigger fight, flight, or freeze for mice it's freeze, but for boys it could be any of the three sort of responses to environmental stimulus. Likewise, the overlap in the most common diagnosed mental health condition seems one that seems to be driven a lot by physiology, right? So ADHD, anxiety, OCD, ODD, and autism are all sort of disorders that tend to be on the higher physiological side. They tend to have a lot of physiological drivers in them. These are not, those sleepers, the kids are overly sort of disengaged and down. They're not those depressive sort of natures. These are tend to be overactive sort of disorders. And then we see the data with regards to poor heart rate variability, even very young, much longer prior to cardiomyopathy-induced sort of cardiac functioning impact. And so what we're seeing is that the stress is real. It's impacting them from a heart rate variability and from a calming standpoint early on in life, much earlier than we would anticipate seeing sort of an impact from a medical standpoint. And so it's important, I think, to understand over time how these things might be co-occurring to create a clinical presentation, because anybody with poor heart rate variability is going to have a harder time adjusting or coping with environments, right? And if that's sort of how your body regulates, then it's really important for families to understand that some of these things are challenging and require a kind of a different approach to managing. And so if we think about this in the sense of, if these boys are incredibly overwhelmed physiologically, then we would expect to see neurocognitive impact of that look like this, right? When you're incredibly physiologically overwhelmed and you're living in a state of fight or flight, you don't learn as well. You do have you do have difficulties with attention, right? You don't process information, again, or recall or learn as well because your learning is impacted, and you have a harder time with sleep. We would see behavioral manifestations like this, right? Like you would have a lower window, right? So things that happen are you're going to have a bigger you're going to escalate larger than you should, and you're going to be out of that window more quickly. You're going to have harder time transitioning, right? You're going to be more hyperactive or restless, kind of, and you might see like shorter fuses. We might see more of that freeze response or selective mutism. And then we would see the behavioral sort of ways of coping with that, right, would look like, well, if everything is just stimulating my brain, then a natural way to fix that would be to hyperfocus, right, all or nothing. If I'm really anxious and I don't know why, and I'm kind of kicked up insidiously throughout the day, a natural way of coping with that might be to reassurance seek, right? I don't know why I feel this way. I'm going to continue to reassurance seek to feel comforted by my parent or caregiver or adult, but that doesn't actually help. It kind of makes it worse, so then I'm reassurance seeking more. It's a negative feedback loop. And that OCD-like behavior with regards to personal items, so that like ordering, aligning, liking things particular way, any of us are like that. It's just more pronounced in these boys. So if you've ever been super stressed and like really cleaned your house and you're like, I just need things this way, this is how I want it, I'm gonna need to like get this stuff done, I need to focus, and you know, you come home an hour later and somebody's moved something. It's not a big deal, but you notice it, right? Because you're like really keen on that environment right now and you just need it to be a certain way so you feel your best. It's a similar to that, but you know, on steroids. So it can be very challenging for them to navigate. And then sleep. And sleep is something that is hard for these kids anyways, and we know they have a big impact on sleep. And if you're not sleeping chronically, we would expect to see any of these buckets anyway, right? And so they're double whammied in that, and that sleep is already impacted. Sleep is really important here, and so sleep is one of those things that's really, really, really important to understand and help parents regulate, because it's one of the bigger factors that's going to kind of be that fuel for this fire. And so the challenges when we start to think about, thinking about these problems for these boys are many. One is the DSM, and the DSM is particularly problematic for dystrophinopathies because how a behavior is defined and labeled, it determines how we treat it. And this is really important for dystrophinopathies because behaviors that co-occur together, cluster together, are diagnosed. And so, your kids are doing, this set of behavior, that means it's this diagnosis, or this set of behavior means it's this diagnosis. And unfortunately for children, there's just a lot of overlap in diagnosis at baseline. And we see this, prominently. The easiest ones to kind of talk about are ADHD and anxiety. Look very similar for kids when they're little, and so do anxiety and depression. And so again, this is where topography becomes hard, because if we're only using topography to kind of understand why we're seeing what we're seeing, the treatments for these things are all very different and might actually make the problem worse if we're wrong about what we're seeing and we're only going on topography. So if you give a stimulant to somebody who's actually anxious, you're going to make that anxiety worse, right? And then when we see that, exaggerated unconditional response to threat and aversive stimulus, is that an anticipatory response, or is that more of a generalized anxiety response, right? If they were producing dystrophin, would we see the same amount of anxiety, or to the degree that we would see? I don't know. I don't think we would. I think if all of these boys are producing dystrophin, we would not, we wouldn't be having this conversation, but I don't think that we would see the degree of behavioral dysfunction that we see in this population. And this is important because how we understand these things impacts what we say and how we recommend therapy and medication and assessment. So for assessment example, because I think the therapy medication one's pretty obvious for most people here, but for assessment, that's really important, because if we're thinking a neurodevelopmental autism assessment versus a neuropsychology assessment versus psychodiagnostic assessment, those all give you very different types of information, and they are very long wait lists. And so if you're thinking, I just need this family, I don't really know what's going on with this kiddo, I don't think this is physiological overwhelm, but I'm not really sure what diagnostic, I'm not worried it's a learning issue, I don't really worry that, XYZ, let's do a psychodiagnostic. That's a very limited evaluation comparatively to a neuropsychological evaluation and a neurodevelopmental evaluation, right? And so knowing what each of these pieces does and the why is really important when you're thinking through what actually are the things that this kid needs to be successful in learning in school, because not all assessments are created equal. Likewise, it's topographically driven, and so it's based on what behaviors look like and what co-occurs together, right? So, and that's overt behavior. So yelling, crying, screaming, the things that are loud, the things that really impact quality of life. And they're important. They're super important, because this is what parents are bringing in. They're like, this is the problem. The problem is, like, my kid is doing these things and it's driving me crazy, or it's really challenging, or I feel for them and I just want to help them not feel so chaotic inside their little bodies. So it's important, and I'm not trying to disregard that this is important. It's just important that we really understand the function that these behaviors are serving for these kids, because it's much more helpful to understand that and to treat based on that than it is the topography of the behavior. And the function is really much more that covert. So how is the brain perceiving? How are we reacting to the stimulus, right? How are these biological and neurophysiological processes kind of working in response to the environment? And when we think about moving away from diagnostic labeling, right, we have a higher rate of diagnoses, as Dr. Henricson talks about in his talk, in general, in this population, much higher than you would anticipate. And when we actually move away from that and we move to features, so you don't have to meet the full diagnostic criteria for a label, right, but you have features of it. You might have a few symptoms, and they're functionally impactful to the boys, that what we see is a significant increase even in rates. And so this is the Dharmahakesh, I'm probably butchering the name, paper from 2020, which I really like, because it really talks about the fact that in this population of 700 kids with Duchenne and 70 kids with DM or Becker, that when we look at actually the things that are impacting the families, 50% reported more than 1 to 2 sort of features that are negatively impacting their functioning. 25% is more than 4, and there's 25% that, said, we don't really have too much impact. So 75% of kids have at least one symptom feature of something that is impactful to their daily functioning. And that's huge, right? Like that's a really large amount within this population, and really helpful to understand, like, even if we don't fully meet criteria for something, we're still experiencing dysfunction that is meaningful and that we need to do something about. And this all is compounded by the fact that it's just really complex to be a human. There's only so many ways as humans that we can overtly manifest complex internal, emotional, and physiological processes, right? And in that way, then, oftentimes a single behavior serves multiple functions. And so understanding context is important. And what I mean by that is, so we think about crying. Crying is a behavior that often reflects an internal manifestation of physiological arousal of some way. We're either excited or happy or sad, right? Like people cry when they're get good news, they cry when they're sad, they cry when they're frustrated, they cry when they're in pain. If we see everyone as crying, which is a topography of behavior, crying is something we can see, it looks like this, and we're like, oh, there must be sad. We might be right? But we might be real wrong. And if we take that and we're like, this means you're sad, and then we treat that, right, we might actually be causing harm because we're treating something that isn't appropriate and might actually make it worse. Or B, we're missing our opportunity to actually validate something good. Or we're saying, hey, like, I'm assuming you're sad, but really you're frustrated, or maybe you're in pain. Those are very different interventions than sadness, right? And so we don't want to just look at crying and assume everyone's depressed. We want to understand why we're crying. Does that make sense? Likewise, the majority of communicative behavior is nonverbal. And so when it comes to developing language, that helps us describe internal nuanced emotional experiences. And for these boys, developing language is delayed. And so they're already kind of disadvantaged when it comes to how do we help them understand what's going on in their bodies, take stock of that and express that to someone else, take feedback and know how to incorporate that into their behavioral repertoire to change how they're responding to that internal process. That's a lot. That's a lot for any of us, even as adults. It's a lot for these boys. And so helping parents and families and y'all understand that expressive language problems and frontal lobe delays are huge when it comes to the boys' abilities to regulate and helping them understand how to help themselves regulate. And until that catches up, it can be hard to do this in the same way that you would expect other kids neurotypically developing the same age to do it. And it's important to help parents understand that. I kind of call it the rule of 2-year delays. So I tell my families, if we're looking at your 7-8-year-old and we're expecting them to regulate like a 7-8-year-old, they might only regulate like a 6-year-old, right? Because they're 2 years behind that. And so helping families understand they might be learning like an 8-year-old, but regulating like a 6-year-old. So building in interventions to help buffer that can be really helpful at school. So what do we do? Well, let's treat overwhelm because that seems to work. We see that in our MDX mice when we sort of restore dystrophin that crosses the blood-brain barrier for at least our MDX 23ers, that we see that unconditioned fear response normalize, which is awesome, which is amazing. And that tells us if we actually do restore dystrophin, hopefully for at least those with this type of deletion, that we can improve how their body is regulating, which then manifests behaviorally into improved behavioral functioning without doing any intervention or demands on the kids. It's kind of a stretch from the mice data, but I'm an optimist. We also see a big effectiveness of antecedent control management interventions in the boys, like with what I do and what I help other people across the country do. So these are things like environmental modifications, scheduled breaks, implementation of token economies. They just seem to work. They help because they shift the paradigm in how we're parenting from a reactive to a proactive. And I'm going to talk a little bit more about that here in a minute. We also see a poor response to exposure-based therapies and strict ABA, like discrete trial training. I'm not saying don't do those. I'm a radical behaviorist myself, and I love me some applied behavior analysis, so don't get me wrong. But often we need to modify our standard protocols, and we need to think about how we're going to manage the arousal impact of what dystrophin is supposed to be doing in the brain and isn't for these kids to help them be able to learn in the same way and benefit from these therapies like we would expect them to. And so with those tweaks, we can see very efficacious treatment here, but it does require some of that thoughtfulness. And then obviously pharmacological interventions are relatively very effective often for treating overarousal. And often if we can find sort of the right match for a kid, and some of these kids are just really hard from a medication standpoint to figure this out with, they kind of have some odd reactions. But for those who are more, responsive, often when we treat overwhelm, we don't necessarily need to do further interventions because once we're kind of regulating that process for them, the behavioral dysfunction kind of resolves. And so I think that also speaks to, the importance of helping parents understand how to advocate for different types of treatment. And so what we're talking about really is we want to move from a reactive, like I was saying, we're catching kids at this upper window, and this is a very common way of parenting. So this is where we're kind of saying, I'm going to let you kind of do it till you get annoying, right? Because like I'm busy and it's easy for me to kind of not pay over attention to you. We're really good at catching kids being bad. Let me just put it that way. And this is a really good way of parenting, and I'm not trying to knock it, but this is where we're getting to a place where we're like, hey, knock that off. Don't do that again. And this is really important for kids to learn how to navigate, because this is where they're like, pushing it, but they know they're getting in trouble, so they can sit with that and they can regulate there. And, for these boys, when we start to do that, we might say, hey, I'm serious. You need to stop. I'm super serious. If you don't stop, I'm going to do this. Hey, now it's done. Now I'm mad. Now I'm taking your iPad. I'm doing X. I'm doing this. And at that point, no matter even you saying that, right? Like, hey, I'm serious. Now you're, getting consequented. They're at the top of their window. They're out of their window, maybe even. They're not going to respond or even learn from that intervention as well as you want. And so we really want to shift from this catching kids once we're like, hey, you need to knock it off, to a more proactive, hey, I'm seeing that you're getting to this place. This is where I can intervene because I know I have enough of my window that I can swing into, because I know you're going to escalate, because that's how your brain does. And I need to be low enough in that window that you can escalate in a place that you're still learning, right? We're still optimizing the physiological impact of learning, right? But you're also able to bring them back down, because once they get out of that window, it's really hard to bring them back down. You're kind of riding that wave till they're out of it. The other things to really talk about with parents in this context, and for all of you parents here to know, is that the other things to really be mindful of are those internal states, like acute aversive internal states, like being tired, feeling hungry, being cold. And make a unique plug for competition, because a lot of the boys like competition, like they like to compete, but they do not do well with competition. They don't handle losing well. They don't handle like the frustration well, and it can kind of kick all of these things off. And so those internal states are really important to be mindful of and to take data on, to be honest. So I have a lot of families who say, oh yeah, like the hunger thing, totally real. Like, we're taking peanut butter around and like 2 tablespoons of peanut butter every few hours, and like we avoid some of these meltdowns. And so understanding that the best ways to manage this is through the environment, or through things that we know kind of physiologically keep kids kicked up, and to regulate that so we can actually teach them how to do this. Likewise is helping parents understand that the role of carrier moms, manifesting carriers, not just Mosaic, but those women that are affected, is that the majority of them, I have met no moms that are carriers that are not anxious, or don't tell me they have some sort of anxiety disorder, but I think it's helpful for them to understand that they have a similar hyperarousal pattern to the boys, not to the same degree by any means, but similar. And that there's this bidirectional impact on mother-boy stimulus dyads in general. And when we look at them with biofeedback data and dystrophinopathies, we see sort of kind of the same pattern, but to a much higher degree. And so it's important for families to understand that their stimulus, and if they are not regulated, if they're escalated, if they get easily frustrated, or if they're a carrier and they have that physiological swing, that there are times that in and of itself is going to drive their boys up. And so sometimes refiguring how they maybe run their household can be helpful. So one of the bigger things is moms do a lot of putting to bed, but bedtime tends to be a very hard thing, and so it can be hard for the boys to calm. And when we shift that to a different caregiver who maybe isn't a carrier, we can see an improved sort of ability to shut down and go to bed, for example. And so the other things that we really recommend as first-line treatment recommendations, and this is in the standards of care, are that we really want to regulate sleep. And sleep is really important, because sleep is one of those things that permeates all of the dysfunctional behavior that we kind of see in general. We want to do a lot of parent and school training and antecedent management interventions. So these are those scheduled breaks, that trigger management, the routines, advocating for one-to-one aids, helping schools understand that, yes, they may carry a diagnosis of autism or ADHD or anxiety, And it's not like your other kids with autism or anxiety and ADHD. These are kids with dystrophinopathy-induced autism, anxiety, and ADHD. And so helping them understand that the ways that they're used to kids responding might not be exactly how these kids might respond. We might need to tweak that a bit. Doing child training and relaxation practices, such as controlled chest breathing, rhythmic chest breathing, as I call it, kind of helping them move away from that diaphragmatic deep breathing, which tends to be a little bit harder for them and cause them actually a little bit more anxiety, I find. And so that can be really helpful. Medications, like helping parents advocate for medications, but also making sure that you yourselves as providers are informed of sort of medications that can be helpful and sort of what standard prescribing practices are around them. Neuropsychological testing and neurodevelopmental assessments are incredibly useful and something that not only is recommended in standard of care, but something that can be invaluable to families to get done early and then to continue to repeat every 3 years for serial testing data. Because it helps the schools, but B, it helps families understand like when they can start to shift certain paradigms of learning to kind of put more demands on their kiddos. And then individual and family-based therapies are incredibly useful. One, because it helps parents learn the alternative parenting skills they need to support these kids, but B, it can help the kids once they're to an age where they can start to do some of this independent learning, learn how, A, their process of escalation, B, develop those body awareness skills, and C, learn how to implement proactively strategies that help them just better regulate throughout the day and allow them to preserve energy, but also to remain engaged and do the things they want to do. I'm going to make a quick plug on things to consider, and this is that the recommendations for early childhood are different than those in late childhood, are different than those in adolescent, are different than those in young adulthood. There is some sort of seeming to be calming that happens in that adolescent area from a emotion regulation standpoint during that puberty range, but then we start to see manifestation of other sort of ways that this anxiety, depression sort of kind of unfolds. And so it's important that when you're thinking about how does this impact the brain, that recognizing that we're going to have a lot of harder challenges in that earlier years, and that does get better, but it not all the way go away. It just looks a little different as they get older. And so really helping the boys understand too that there's, learning how to manage this disease is part of, from a neurocognitive standpoint, part of it, just like we learn how to manage our muscles. It's important to kind of have the conversation that the need to train these kids to overcome those things that are hardest for them is really important. And so with chronic illness, it's really common for families to kind of feel bad, and any human feels bad when kids have to go through things that are just challenging and hard and horrible, and this impacts them as kids. And so we tend to do things like we change our demands or we change our expectations, which is fine to a degree. But there are things that might be harder for these kids, like socialization, joining groups, doing things that are easy to kind of be like, you already have enough on you, I don't want to push that. But those are the things that are really important sometimes to help them learn so that we can build on that skill set later. And so if your kid really struggles to talk to people, helping them start to do that young and develop a way to do that is really, really important, because without that, they're not going to be able to you're not going to be able to advocate for themselves as adults in their medical care, and quickly can find yourself sort of in this position of sort of doing all the things for them when it comes to their medical care and talking for them and all that. And so kind of thinking about, like, if your kid loves math, right, and they hate to read, you don't just let them do math, you make them read too. Sometimes you make them read more because they're good at math, so you don't make them do the math part as much, right? And so it's important that, just like any kid, that the things that are harder are the things that these kids tend to want to do the least from a behavioral learning standpoint, are the things that sometimes we need to kind of prioritize in order to build upon them later down the way. There's also potentially a parental skill deficit. I don't mean this negatively, but in the fact that, like, you've never parented, or maybe haven't parented, or haven't parented in this way a kiddo with a dystrophinopathy, or maybe you have, right? But they're all different because they're all unique young men, and you haven't seen that. Your parents didn't parent you like that because you don't have dystrophinopathy, and so you're operating in the dark, and then there's a need to know that to parents, because a lot of parents, I think, carry a lot of guilt around, like, this is my fault, I'm doing this, I'm not a good parent. Y'all are the best parents. The problem is that we're just learning how to help parent these kids. And so you need to have grace, and you need to be kind to yourselves and say, I'm doing the best. My kid, as long as your kid's happy, right? Like, we can figure out the behavior stuff, right? And it's important that, we're recognizing, like, you are working your hardest, and so are they. And the behavior is not because of anything anyone's doing wrong. And then one more plug just about older generations who likely have, different, sometimes very strong beliefs about parenting approaches and discipline. And these are often the people that, you look up to as caregivers, might be your parents or grandparents. And they might have thoughts and things about how you should be parenting or not parenting, and they feel very strongly about them. And that can really impact you. But it's important to know that just as you've never parented these kids and don't know, like neither have they. And it's a difficult thing to give that education around, but it's really important to help them understand the role of dystrophin in their brain so that you are not battling the other people trying to help you, because the more consistency, the more routine, the more on board and on the same page everyone is for parenting these kids from a proactive standpoint, the better off they're going to be and you're going to be from a, your sanity standpoint. Thank you so much. I've really enjoyed giving this talk with you guys today, and I'm happy to take questions. Thank you so much.
All right. Well, thank you to Natalie for that fantastic talk. A quick note about the agenda. We should be transitioning to the next panel, but there was a slight change in that panel. So we've got about 10 minutes for questions. Erik, we can head up here. So if you have your questions, go to one of the stand mics in the aisles, and we would love to answer them. Erik and Natalie, I will say we have one question that came in online that I'd like to share with the group. And I want to be mindful, I know neither of you is a psychiatrist, but it is a medication question.
That's
and
a
that
Natalie.
question
That's a Natalie
is,
question.
that question is, what are some medications that can help with other meltdowns that commonly occur? So Natalie, I know you talked about some really great strategies for managing meltdowns, but do either of you have any thoughts on some of the most commonly effective drugs?
Well, you're right. Neither of us are physicians, so we can't make that specific recommendation. But when when you look in the standards of care and what we kind of see are helping are those things that like SSRIs that are well tolerated, things like alpha agonists that can kind of help sort of blunt some of that physiological arousal ability. And obviously for kiddos who have sort of true, genuine diagnostic flares like ADHD, sometimes they do really require stimulants and benefit from them. But often I think SSRIs and alpha agonists tend to be well tolerated and are consistent with the standards of care and have really good standard prescribing practices associated with them. So I feel like they're a lower risk compared to other sort of medications that are available for providers, and most providers are more comfortable with those classes.
Erik, do you have any additional thoughts there?
Yeah, I think part of the key for the behavioral meds management from a multidisciplinary team standpoint is that there's a lot of trial and error in behavioral meds, and so clear communication between the different members of the care team, the neuromuscular folks versus the psych and behavioral folks is super important, but also communication with family members, with teachers, with people who are raising concerns about behaviors in certain environments. So I think, or certain times a week, is it are behavior challenges are they a weekday challenge? Are they a weekend challenge? Is it in the morning? Is it in the evening? There's a lot to dissect there to sort of pick the most effective ways to intervene and to sort of help people achieve to their best possible ability. So I think that that would be kind of the place to start when having discussions about meds as well.
I think it just speaks to the importance of having that multidisciplinary care team, right? So you're working with your neurologist or your neuromuscular specialist to figure out what steroid regimen makes the most sense. And you're working with your psychologist to work on some of these strategies in the home and at school. And you're working with a social worker and your teachers to figure out, IEPs and 504s to make sure that accommodations are taking place in school to make you successful. And then potentially pulling in that psychiatrist to help with the medications too. So it's certainly a complex diagnosis, and we need lots of different people on the team to help support that. So you guys are both brilliant and critical parts of this.
I think taking good notes as a family member is really important as well, just because the behaviors that we see on the clinic side are only a very small slice of everyday behavior. So taking notes from teachers, taking notes from family members, and just getting an idea of just having a clear idea of what kind of behaviors occur when they're great and when they're not so great. And like Natalie was saying, understanding what kind of, what pushes the arousal threshold is really important, and that, care teams are going to rely on parents and teachers in the community to understand that for the individual.
Absolutely. Thank you both. All right, looks like we do have somebody over at the stand mic. What's your question?
Hi, I have two boys, 20 and 23. The older one has delayed puberty, and so I'm wondering if you could talk a little bit about how that delayed puberty might affect brain development, social cognition, and interaction.
Yeah, that's a fascinating question, and no, and I don't say that to discount it. I think that there's a huge amount of, like I said earlier, brain rewiring that occurs during puberty in response to sort of the hormonal levels in the body. And do we fully understand kind of how that works in the context of glucocorticoid therapy, or even how does the developing brain differ in the context of dystrophinopathy? There's something, it's really interesting, it's something I'm curious to look at, is there is an observation among many family members and clinicians alike that, sort of during puberty and after puberty, a lot of guys with DMD kind of tend to like chill out a little bit. And some attribute that to to fatigue and muscle strength. But there's this, the puberty is a time of really extreme remodeling of brain pathways. And I suspect that there's a part of that that's causing that as well. And we're, hopefully in the next short while, we'll start to understand some of those things.
Can I ask a follow-up question?
Of course.
Do you think testosterone therapy helps with are there some positive outcomes for the brain if they are on testosterone therapy?
Natalie, do you have a sense of that?
Good diversion.
That's a really good question. I've had other families ask. I would say I don't know, but I'm very curious, given what some other families have reported after starting hormone therapy like that, like testosterone therapy.
Great. Thank you.
That's a great question. I think we have a lot to learn there. I haven't heard
Somebody
that
will write
before.
a grant on that.
All right, any other questions from the crowd? Don't be shy. There are no stupid questions.
Great.
Yeah, go ahead and just run to the mic real quick so we can all hear your question.
Hi, it might be an early question, but at this point with gene therapy going on, do you see kids after gene therapy? Do you see the effects of gene therapy on the brains, Duchenne brains?
I think the short answer to that is that we haven't done a very effective job of looking and measuring those things. One of Francesco Montoni's group papers came out just recently, within the last maybe year and a half, where they were looking at dystrophin gene expression sort of in the muscle with some of the exon skipping. And they were looking at multi-organ effects. And there's like one or two lines in there that said, oh yeah, and we saw dystrophin expression increase in the brain. And there was some behavioral normalization of the mice, and it was like ... So yeah, I think that there seems to be some opportunity for some of the therapeutic approaches to maybe start to work on these pathways. I think we need to figure out how and what we ought to be measuring, and I think it's a fascinating area to go into. But the sort of brain and behavior group that PPMD has put together, it's one of the things we've kind of targeted as an area of interest. So we'll find out, hopefully.
All right, looks like we've got time for about one more question.
I have a follow-up question, if I may ask.
Oh, yeah.
In terms of mutations in dystrophin, where do you see the most problems with cognitive function, for example, like location of the mutation, and how would you categorize the cognitive function based on the location of the mutation?
I think, feel free to jump in, Natalie. You know, one of the things that I think we're starting to understand is that the sort of social and behavioral part and the emotional regulation part is a little different. It's separate from the commonly sort of IQ intelligence, cognitive function. So which seems to have be more related to some of the shorter isoforms of brain-specific dystrophin that occur in like the cerebellum and a couple of other structures. So in terms of level of importance, I guess there's the intellectual capacity part, and then there's the social interaction part, and I hesitate to kind of put heavier weight on one or the other. I think that more common is the social and emotional regulation portion in terms of the commonality across people with different genotypes. But again, there's a big spectrum of the level of impact that has on daily life. So I'm not sure that's a good answer for that question, but I think it underscores the reason for needing to kind of look at early evaluation of the individual, because different people will have different strengths and weaknesses.
Thanks so much, Dr. Henricson. We are at time, and I want to be mindful. Dr. Henrikson's going to be here all weekend, and he's got a couple of other opportunities where he speaks, so I'm going to speak for him and say grab him in the hallway with your questions if you didn't want to share them out loud. Right. And at this time, we're going to go ahead and do a quick mic swap and transition over to our research panel, Strategies for Mitigating Inflammation and Fibrosis. So hang tight with us. Thank you so much.
Thank you very much. Thanks, Natalie.